So we've got a pathology that's situated here in this hair follicle, right? This is abnormal. It's acanthotic. It's got hyperkeratosis, hypergranulosis. So what can you say about it by definition if it's got hyperkeratosis, hypergranulosis, and it's on a hair-bearing skin? What do you know that means the patient is doing to themselves?
Oh, they're rubbing themselves. They're like scratching and rubbing.
Scratching and rubbing. It's lichen simplex chronicus. Good. So here, what have we got right in this area?
Collagen.
Yeah, it's degenerated collagen, and probably these are probably degenerated elastic fibers also. And there's neutrophils here. This is forming a little tunnel, and it's getting this transepidermal elimination of these elastic fibers here, and probably degenerated collagen bundles. So what's the diagnosis?
Perforating elastosis.
Yeah, elastosis perforans serpiginosa. That's the other name for it. And basically, in these patients, they have something going on metabolically. They have maybe Down syndrome, and they've got some kind of altered collagen biochemistry. They maybe have renal disease. All of these diseases, the perforating diseases, are basically look alike. They all look the same. Curley's disease, they're all the same disease. You take those patients and basically stick them in a coma, most of that goes away. These are not spontaneous diseases. They have to be doing something to their epidermis. Patients with Down syndrome, they like to rub and scratch their skin. And so basically they end up getting the lesions secondary to that, and they may not have any kidney failure. So here's the elastic tissue stain. It's really pretty dark, but you can see a lot of these dark black structures here. They're elastic fibers that are degenerated and getting ready to be transepidermally eliminated out of this acanthotic epidermis here. So we have a couple of other examples. This one's not quite as good because we had to cut deepers and kind of most of it sort of went away, but it's the same basic process here. You've got these follicles here that have got neutrophils and degenerated collagen or elastin or both being transepidermally eliminated. So the host is just saying it's almost like a splinter. It's like there's foreign material. Let's get rid of it. So it goes out the epidermis. Patients pick at it, scratch at it, gradually goes away. I'm not even going to show that one. And here's one last one. So it's the same thing. See how repeatable it is? It looks the same every time. You've got this tunnel that gets formed when patients rub and scratch. If you just have this side, that's prurigo nodularis. There's no perforation over here that you can see. So we're off to the side of it there, and you can see it's got beautiful lichen simplex. So that's basically proof positive that you have to be scratching these things for this to happen. Here's one that was called reactive perforating collagenesis. Okay, well, but these are basically just the same process. So, the textbooks say, well, this one's got collagen in it. The other one's got elastic fibers in it. But how do we know that there's not both in it? So, if you got renal failure and you've got uremic circulating byproducts that localize to your elastic fibers and your collagen bundles, and it causes this sort of funny biochemical alteration of the collagen, and then you get inflammation and you start rubbing and scratching it, well, then you get this process. So the first thing that happens is the pruritus. This stuff happens secondary. So this isn't just you need to know the pattern. You need to understand the concept of transepidermal elimination, but basically understand that the pathophysiology is pruritus and rubbing and scratching. You don't get this, you don't get this. Okay, this one's better here. You can see low magnification. This is the one you want to see. Okay, this is the classic pattern. This is what you want to see here. It looks like steel wool. You guys know what steel wool is?
For scrubbing pots.
Yep.
Okay, you've seen steel wool, Brillo pad.
Yeah.
And go online and look at it, because that's what this stuff looks like. These are these elastic fibers. They're little clumps, tufts of elastic fibers that calcify. You see the calcification here? It's beautiful. You don't need a von Cass's stain for this. You can basically just look at it and see it with H&E. So this is a gorgeous example of elastosis perforans serpiginosa. Now there's two types of that condition. One type is an autosomal, I believe it's recessive, that occurs sort of like chicken skin on the side of the neck, and they get these fractures in Brooks membrane in their retina. And they also get abnormalities in other areas of the body with their elastic fibers, like the aorta, heart valves, joints. So that's the inherited type of this condition. The other type is due to penicillamine ingestion. And you can't really tell here because we can't get high enough with just this slide scanning. But if you look really, really hard at the elastic fibers that are calcified with that are penicillamine, they have the so-called bramble bush morphology. So if you look at that carefully, you'll see like an elastic fiber with a little nubbin that kind of comes off at 90-degree angles on those. And if you see that, it strongly favors penicillamine-induced PXE. And I've been following a man in my clinic now. I think maybe, did one of you guys see that patient with me a few months ago? Maybe Marissa, you saw him with me. He's got penicillamine-induced EPS that is because he took penicillamine years ago for oxalosis. And he's got stuff all over his body. He's got it in his heart. He's got it in his aorta. He's got these plaque-like areas on his skin. He's just kind of lived with it for years. He's never really had any real major problems with it. But his skin sort of looks dry, and he's got these sort of funky-looking brownish crested areas. When you biopsy them, they look like this. And they have that classic bramble bush morphology. Now, there's one other setting where you can see PXE-like changes. It can be idiopathic, not associated with any disease, as kind of a reaction pattern sometimes in patients that have had C-sections and people that get stria and things like that. They can sometimes get a secondary PXE-like change, and you can sometimes even see that in other sclerosing conditions like necrobiosis lipoidica. So it can occur in a lot of other settings, but the classic changes are either here or in the inherited type. You could do an elastic tissue stain for this, like a VBG. You don't need to. You can do, a von Cass's stain. You don't need to do that either. So you can make the diagnosis pretty much without any real problem there doing that.
Wait, so this is PXE or elastosis perforans serpiginosa?
That's PXE. PXE.
Okay.
We did EPS earlier. That was the stuff where you got the transdermal elimination.
Okay, that's what I thought. Okay, this is PXE.
Okay, now this is a cruddy biopsy in this case, unfortunately. The reason we showed it is because the elastic stain is positive. This is an example of an anetoderma. Okay, when you're seeing an anetoderma, you usually need a punch biopsy, and you usually see the subcutaneous fat sort of sitting up here. It kind of got separated here, so let's just pretend like this was a deeper biopsy, and then the fat was kind of sitting around in this area right over here. So that's what it looks like when you look at a low magnification of a real, honest-to-goodness anetoderma. And if you do an elastic tissue stain, I mean, the tissue itself looks pretty normal. So if you lose elastic fibers in your skin, like you look at regular, like a biopsy, somebody's got Ehlers-Danlos disease, and maybe they've got no elastic fibers in there, it doesn't look abnormal unless they've got a scar or something like that. There's no inflammation. It kind of looks normal, except if it's an anetoderma, you can really see the subcutaneous fat that's really higher up than it should be. But here, it doesn't look really abnormal. So you really need a special stain for the elastic fibers to see if there's any involvement there. And so here we have an elastic tissue stain. And notice that there's basically no elastic fibers here. There's a few, but there's strikingly decrease in number. So when you see a real, true, honest-to-goodness anetoderma, there really should be almost no elastic fibers. So there's none in the papillary dermis. There should be some there, and there seems to be a decrease in number here. So this isn't the world's best example of it. We don't get too many biopsies of it, but if you see a real classic example of it, it should basically be nothing. Let's look at another one. This is better because this is a deeper biopsy. And let's see if we can orient it right here. Okay, so here's the specimen. You really don't see a whole lot going on here. I mean, the collagen bundles really don't look abnormal. Here you got some subcutaneous fat that does look like it's pretty high up here in this one field. So again, let's take a look at the elastic tissue stain here. And this one has none. Okay, this has got 0 elastic fibers. This is just staining the collagen bundles here. So this has no elastic fibers. The elastic fibers are gone in this case. So this is what you're supposed to see in a real, honest to goodness anetoderma. No elastic fibers. And see these little pockets of subcutaneous fat up here? You can get fat metaplasia, but in this case, this was really due to the subcutaneous fat was kind of herniated up into the dermis. And when you see these patients clinically, they have sort of these outpouchings. It's kind of a pseudo tumor. And you walk up to them, you stick your finger in, it's like sticking it into a balloon that's halfway inflated. You can just push it right into their skin because it's really totally atrophic. Here's another example. Okay, this one may be the best of the bunch because look how much the dermis is separated here. All this subcutaneous fat is sitting right up here in the reticular dermis. You shouldn't see that. And these collagen bundles are really markedly separated. I mean, this is really, you would really think this person would have an atrophic process when you see this. So this is a nice example of an anetoderma here. And I think we might have an elastic tissue stain in this one also. Yeah, look at this one. This one's got basically no elastic fibers here either. Okay, so no, basically 0 elastic fibers, subcutaneous fat that's herniated up into the dermis, and the separation of these collagen bundles. I mean, this is a really classic example of an anetoderma. So there's one disease. Here's a piece off to the side. Notice, see, there's 0 elastic fibers here. It's even better than one before. There's none here. So in a fully developed anetoderma-like lesion here, no elastic fibers, totally atrophic skin. Now, what other disease do you know where the subcutaneous fat is sitting up in the reticular dermis and it shouldn't be there? Anybody know? Nobody knows.
Cutis laxa?
No, basically that would be basically Goltz's syndrome. Goltz. Okay. Okay, so this one's just another one. Let's skip this one. These basically just show you this alteration of the collagen bundles here with the loss of elastic fibers. Actually, those other ones said they were cutis laxa, but they look the same. So basically, this is another example of just one of these altered dermal collagen bundles. So they basically all look the same. Cutis laxa, anetoderma, they all kind of look similar. So that's basically loss of elastic fibers. That's the main take-home message for those. Okay, so those are the ones that are the lectures. There's really not a lot in the lectures for these. So I think you know everything you need to know if you just kind of know those basic diagnoses.